Alison Holt, well, we asked NHS England to come on to Newsnight tonight to discuss care provision for patients with brain injuries. Nobody was available. But Dr. John Etherington, National Clinical Director for Rehabilitation and Recovering in the Community at NHS England, gave us the following statement. NHS England is working to improve rehabilitation services, including specialist rehabilitation services for people with complex needs, such as those following a head injury. These include the establishment of a clinical reference group to examine the commissioning of specialised rehabilitation services, the development of regional trauma networks to review services, which has already led to service improvements, and a review of funding for long-term conditions is also underway. This work is vital to improving outcomes for patients. Well, here tonight we do have Kate Allatt, who survived locked-in syndrome and knows just how vital good rehab treatment can be, and Professor Lynn Turner-Stokes, a rehab specialist who was asked by NHS England to lead the push to devise new guidelines for the rehab treatment of brain injury patients. Good evening to both of you. Professor Turner-Stokes, what do you make of Grant Clark's story?
Well, it's difficult to comment on individual cases, of course, but really that doesn't look at all the sort of standard that one would expect to have. And I think the point about that is that it really underlines the necessity to have patients who have complex disabilities cared for by staff who have the
staff that was specialist treated in that. I mean, it's quite extraordinary, isn't it? It calls itself a specialist unit and had one trained specialist?
And the British Society of Rehabilitation Medicine has set out some standards for what we would expect in the way of qualified staff to be on those specialist units, and the normal recommendation is at least a third of the staff to have specialised nursing staff to have specialised training.
Kate, before I talk about what happened to you with your locked-in syndrome, I know that you now campaign on behalf of relatives and families. Presumably Grant Clark and indeed Mark's cases are not isolated.
They're not isolated. There are a lot of people I deal with who have great experiences in rehab if they get the opportunity to go to rehab, which isn't always the case. So I have to say that there are some good examples. Mine was very good, but this was appalling. I mean, appalling. I mean, my heart goes out. But how often do we see vulnerable people in society being neglected like that across all sectors? And
for you, what happened to you?
Well, I had a brainstem stroke with locked-in syndrome in February 2010, and basically that left me unable to do anything to communicate through blinking. That was it. Nothing else moved. I felt everything, but I could move nothing.
And the process of getting better, is it about a partnership? I mean, the way that nurse was talking to Grant like a child.
Yeah, well, again, I think that's appalling, and I think that's very patronising, and I think that's very controlling. I think that the key thing in rehabilitation units, there should be a specialised neuro-OTs, speech therapists, neuropsychologists, there should be neurophysiotherapists, and I think especially neuropsychologists, because I think as part of a rehabilitation programme, you need to have the loved ones on board, you need to have the
because they're terrified too, presumably, because you were unable to communicate, so they wouldn't really know if you were receiving proper care or not.
Exactly, and also you have to also factor in the fact that loved ones a lot of loved ones tend to believe the doctor in the white coat because they don't know any different.
So part of the problem is that you can't be guaranteed, as we said, and in fact, what did Professor Michael Baines said? He said there are units that don't provide proper coordinated rehabilitation at all, that it is another form of postcode lottery.
Well, indeed, and I think it's fair to say that up until now, rehabilitation has been something of a Cinderella specialty. Much of the focus has been on acute and frontline services, and specialised rehabilitation just really hasn't had the level of prioritisation that we would really need to see.
Is that because, as Professor Baines was saying, that the initial injection of cash is quite high for rehabilitation, but it's down the line that the savings are made, and the trusts look and go, we can't afford this?
Yes, that's so. It does look expensive to start off with, but when you see those advantages play out over the life of the patient, and we're often looking, as indeed in this film, in quite young patients who've got the rest of their lives to
isn't that the problem with the budgets of hospitals? I mean, you know, they would like perhaps to think about the outcome 3 or 4 years down the road, but what they're concerned about is their budget over the next 12 months.
Absolutely, and that's partly the way that the system is funded at the moment, going from year to year.
And would you suggest it shouldn't be funded like that?
No, I think one would like to see longer term planning and strategy, really trying to make sure that we take advantage. We have, as Mike Barnes said, really good evidence that rehabilitation can be cost effective, and what we need to make sure is we do reap those benefits.
Oh, you're on just the question of your rehabilitation. How did that play out? Were you with the same staff? Did you have continuity of care?
Well, I was in ICU for 9 weeks and then went to Osborne 4 straight there, actually, which was a bit of a shock. But they were an amazing team, they really were. But they had a very driven patient. And I think motivation of the loved ones, motivation of the patient, and the team, who identified with a young mother with 3 kids at home, you know, it was easy for them to do something for me because they could see my plight and feel my plight. And yes, they got out of me as much as I got out of them, because it was two-way and I worked hard. And I think that's important. I think also rehabilitation, I have to say that I think the rehabilitation should start a lot earlier than it does in this country. It should start in ICU like it does in Denmark, 2 days after the coma.
Thank you both very much indeed.